I first learned how to do anterior hips in residency, and then again in fellowship. I had a lot more exposure to it working with surgeons that had years of experience doing anterior hips. I also went to two different industry sponsored seminars to practice on cadavers to learn special techniques and different ways to do the approach.
Okay.
A hip replacement candidate is someone that has bone on bone arthritis or has a condition called avascular necrosis where the femoral head has died and collapsed, leading to an arthritic type condition. These patients we know don't tend to get better with conventional treatment such as physical therapy and injections, and they are candidates for hip replacement. As far as anterior hip replacement is concerned, it has to come down to some of the different factors in their anatomy, specifically if they've had previous surgery on their hip or if their hip didn't grow properly and they have what's called hip dysplasia. They may not be a candidate because the exposure and the options as far as implants are somewhat limited with the anterior approach, and that's a discussion I have with them based on their anatomy that I see. Patients that may not be a good candidate for anterior hip replacement are the people that are morbidly obese. We know obesity is a problem for all hip replacement and for other medical problems, but the more abdominal fat that a patient carries, the closer that incision is to that groin area, and the more concerned I become with the possibility of a wound problem or an infection. That's a discussion that I have with the patient, and based on their body habitus, we decide the best approach for them. There are three main ways that a hip replacement is done in the United States. There's a posterior approach, which comes in through the back of the hip, an anterior lateral or a lateral approach, which comes through the side of the hip, and a direct anterior approach, which comes in through the front of the hip. When you do an anterolateral approach or a posterior approach, you have to split some of the large muscles around the hip and release some of them off of the hip in order to pop the hip out to do the surgery. With a direct anterior approach, you move those muscles to the side, you pop the hip out the front, you remove the top of the femur, and you remove a small amount of bone from the inside of the acetabulum. You place a metal shell inside the bone and a metal spike inside the bone here that has either a metal or ceramic head, and that head then articulates with the plastic, and that allows the patient to walk without pain. The implants are the same no matter how I do the approach. It's just how I get them in there and the tissue damage that occurs putting it in. So the complications of an anterior hip replacement are very similar to every other hip replacement. Complications such as infection, bleeding, injury to nerves, fracture, instability or the hip popping out, and then wear-related issues. The complications that are different with an anterior approach is one of which is numbness along the outside of the thigh or the front of the thigh muscle. It doesn't affect how the muscle works, but you can get some numbness in that area. It doesn't usually cause a lot of pain, but it is something I warn patients about. With a posterior approach, your concern is the sciatic nerve that runs in the back of the leg. Again, it's rare to damage that, but if you do, that can cause significant weakness in the lower leg, so that is one of the complications that I talk about. As far as other complications, bleeding I have found with our modern techniques and medications that we can use that bleeding has really been the same for me in probably my last 50 hips going from the front or from the back, so that's not really that big of a difference. Infection rate, fracture, things like that are relatively the same once the surgeon has been through their learning curve and feels comfortable with the approach. The benefits of an anterior approach are similar to the benefits of all hip replacement in that there's usually marked improvement in pain and ability to ambulate or walk without an assistive device. The specific advantages of anterior versus some other approaches is the patient tends to have less pain early on, especially in the first few days and up to the first 6 weeks. At 6 weeks, I've noticed that the patient's improvement further mirrors that of the posterior approaches and other approaches, and at 3 months, I cannot tell the difference in how a patient walks or how they feel on what way they had the approach. The first couple of weeks, I notice a difference, but after 6 to 12 weeks, I really don't see a difference. I don't see any reason that the implants will last longer from one approach to the other. That is an implant-related issue, not an approach-related issue. Other advantages of it are that patients tend to be able to climb stairs earlier and maybe get rid of their cane or walker earlier with an anterior approach. But again, 3 months, no difference. The dislocation rate in the published literature is lower with an anterior hip replacement, somewhere in the 0.5 to 1.5% of patients, whereas with a posterior approach, it's more in the 1.5 to 3%. If it happens to you, it's 100%, but it is a lower risk, and I don't put the classic restrictions on my patients with an anterior hip. I allow them to sit in a low chair or sit on a regular toilet, and I don't worry as much about them bending their hip up after a hip replacement. I've performed the majority of my hip replacements at the Dune Surgical Hospital. We have the specialized table in order to be able to do them, and the staff are very familiar with me doing them there. I have just started doing them at Mercy Hospital. They now also have the table that I need, and they're becoming more and more accustomed to it. I have used it in some patients that have had a femoral neck fracture, and I put a total hip in them, and I've been using the anterior approach for that in selected patients. I've done over 100 of them now. I feel very comfortable with it, and about 80% of the patients that come into my clinic with hip arthritis or AVN are candidates for an anterior hip, but I talk to them about the pros and cons. Physical therapy isn't routinely required after the patient leaves the hospital. During their hospital stay, they get a set of exercises that they will do, and they work on stair climbing and getting in and out of a car, things like that. At the 2-week visit, if the patient feels like they're not progressing as well as they would expect, we can start some therapy at that point. Also, if the patient was having some trouble during their hospital stay, maybe therapy may be indicated, but about 90% of my anterior hip patients don't require therapy after surgery. They're able to go directly home, and they just need some help with laundry, cooking meals, driving. Patients with a left hip replacement, I routinely won't let them drive for 2 weeks after a surgery. And if a right hip replacement, it's 4 weeks. That's not a negotiable thing for me. But I've had several patients that at that 4-week mark feel very good about driving, and they feel safe to do so. My permanent restrictions for hip replacement patients are the same regardless of approach. I don't like my patients to run, jump, or play contact sports, but cycling, hiking, walking, swimming, all those things are allowed. So patients can still exercise, they can still be active, they can run to get out of the rain or jump over a mud puddle, but I don't want them to run a 5K. It's just too much pounding on the implant, and I worry about the implant wear over time.